So we can start.
Okay. Any comments from anyone? If not, we're going to go ahead and get started. All right. So here we go. So these are the first three, and these come to us from Wolf Apps. So Wolf Apps had their Congress, and they sent us what they felt were the top three presentations. So first of all, incredible congratulations to these three authors who submitted these fantastic presentations. But unfortunately, we're going to have to pick one whose video we play. So here were the three. The first one was from Dr. Rachel Livergant from the University of Alberta in British Columbia. And it was with postoperative morbidity and mortality in the pediatric indigenous populations, a scoping review and meta-analysis. So this was a review and a meta-analysis of 14 studies to assess which inequities exist between surgical outcomes in pediatric indigenous and non-indigenous people on the American and Oceanic continents with regards to post-op complications, morbidities, and mortality. So that is the first one. Amazing job, Rachel, on an amazing paper. Congratulations for being accepted as to the top presentation from Wolf Apps. The second one is Dr. Rustan Yuldashev from the Tashkent Pediatric Medical Institute in Uzbekistan. And he presented angiographic patterns of portal venous system in children with extrahepatic portal hypertension and its etiologic and clinical relevance. The purpose of this study was to study the relationship between angiographic patterns of extrahepatic portal vein obstruction and its etiology and clinical manifestations. All right, so that was new. That was number two. Congratulations, Rustin, on an amazing paper. Really impressive to be selected, not only at Wolf Apps, but also to make it to the best of the best. And last but not least is Professor Tran Ngoc Son from St. Paul Hospital presenting single incision laparoscopic percutaneous extraperitoneal closure of the process vaginalis without hydrocelectomy in the management of primary hydrocele. So they looked at the laparoscopic approach of the management of hydroceles without actually performing a hydrocelectomy. They performed a prospective study between June 2016 and December 2021, and their aim was to study the feasibility and effectiveness of the laparoscopic approach for patent process vaginalis without hydrocelectomy for treating hydroceles. So those were the three. We've got review and meta-analysis of inequities in indigenous and non-indigenous. We have the angiographic patterns for portal venous hypertension, and we have the use of the laparoscopic approach for hydroceles without hydrocelectomy. Unfortunately, we're going to have to pick one, so let's open up the polls. Everybody vote. We'll play a quick video while you vote, and we'll see which one advances on to the next round of the best of the best. We'll see you in a minute.
That feeling in your heart.
It's always been there.
It's curiosity.
Empathy.
Discovery.
It's a love for what we do.
Both the children we care for
and the people we stand side by side with.
At Cincinnati Children's,
we know it well.
It's our purpose.
Care drives us.
Science moves us.
Collaboration empowers us.
Discovery inspires us.
We are touched by humanity
and propelled by compassion.
This isn't our job.
It's our calling.
And we answer it every day.
For every family.
And every child.
And every future.
To heal.
To discover.
To teach those who will one day change everything.
We are Cincinnati Children's.
From one location serving one community in 1883.
To patients and employees from around the world.
We're 17,000 strong and growing.
And we are changing the outcome.
Together.
Okay, well, it was a close one. It's still changing, but I think we can call it. I think it's close enough to call at this point. It looks like the winner was the single incision laparoscopic percutaneous extraperitoneal closure of the process vaginalis without hydrocelectomy in the management of primary hydrocele in children. So if we can, I don't know, are we able to bring the author to discuss this paper? But if not,
Let's see.
Let's
the
go ahead and
presentation.
play the video. We'll play the video and bring the surgeon on to talk about it. So Isla, let's go ahead and roll this video.
Dear colleagues, ladies and gentlemen, thank Wolfapps and Slaykoran MD for giving me the opportunity to present our work, laparoscopic percutaneous closure of patent processus vaginalis without hydrocelectomy for childhood primary hydrocele. The traditional hydrocele repair is open repair with an inguinal incision, highlighting under PPV and hydrocelectomy, which can be total or a partial of fenestration. Laparoscopic surgery, or LS, is increasingly used in the treatment of pediatric inguinal hernia, but not yet popular in the treatment of hydrocele. The aim of this study is to evaluate the feasibility and effectiveness of single-incision laparoscopic extraperitoneal closure, or SINPEC, of PPV without hydrocelectomy in primary hydrocele in children. We perform a prospective study on all children with primary hydrocele treated at our center for 5 years period, with inclusion and exclusion criteria as shown. For our SINPEC procedure, 2 trocars were placed at the same 10 mm single umbilical incision. Under the laparoscopic vision and with the assistance of the grasper, PPV was closed extraperitoneally at the internal inguinal ring with a 2-0 suture using a percutaneous needle with a wire lasso. No hydrocelectomy or fenestration of hydrocele was performed. The hydrocele fluid was pushed back to the peritoneal cavity via internal ring before the closure of PPV by external manual pressing, and with this step was unsuccessful. The fluid was evacuated by a percutaneous needle puncture. (553) patients were enrolled in this study, with a median age of 34 months, ranged 2 years to 14 years. Ipsilateral patent PPV was found in all the patients, and in nearly 30%, there was no obvious communication between the hydrocele with the peritoneal cavity. The median operative time was 70 minutes, and the median post-operative stay was 1 day. There were no major complications, and at a follow-up of 41 months, the recurrence rate was 0.36%. The post-operative cosmesis was excellent. Some meta-analysis showed that laparoscopic surgery has the advantages of less trauma, reduced post-operative pain, faster recovery, improved cosmesis, and fewer complications than conventional open surgery, with the advantages of ability for exploration of the contralateral internal inguinal ring. We know that simple puncture and fluid aspiration alone is ineffective in the management of hydrocele. The principles of laparoscopic management of pediatric hydrocele are still controversial. While some authors use the same principles as open surgery, closure of the PPV of the internal ring, and hydrocelectomy or wide fenestration of the cyst. Other authors perform high PPV ligation without hydrocelectomy with good results. In this study, we performed SINPEC for PPV without hydrocelectomy. We found that ipsilateral PPV or open internal inguinal ring was present in all cases. In nearly 30% of our patients, the hydrocele has no obvious connection with the peritoneal cavity. In these cases, we still ligated the PPV and evacuated the fluid in the cyst with a percutaneous needle. No recurrence was recorded. We suggest that in such cases, there is a still discrete one-way passage of the peritoneal fluid towards the scrotum, but not the opposite. The fluid in the primary hydrocele is actually the peritoneal fluid, not fluid produced by the hydrocyst itself. So there is no need of hydrocelectomy. You can see in this slide that laparoscopic management of pediatric hydrocele without hydrocelectomy had comparable outcomes in terms of recurrence compared to other reports with hydrocelectomy. In conclusions, If silateral PPV was present in all cases with primary hydrocele in our series, our technique of SynPEG of PPV without hydrocelectomy is feasible, safe, with excellent postoperative cosmesis in the management of primary hydrocele in children. Thank you for your attention.
Okay. All right. Welcome, Dr. Sun. Thank you for joining us.
Yeah, fantastic paper. Remember, we have 3 minutes, and at the end of the 3 minutes, we will hear a sound of a ring. So let's start talking.
All right, perfect. Tony, thoughts? I know I have a ton of comments, but I want to hear yours. We got 3 minutes.
Very interesting, and I think people are doing it, and it was a very good thing to study. The question I have for you is, when you don't see a patent processus, I believe you still ligated it. Is that absolutely necessary? And I assume then, by virtue of that, if you just aspirate a hydrocele and it recurs, there's always a patent processus. Is that correct?
Dr. Sun, can you hear us?
Yeah.
Did you hear his question? So let me go ahead and address that, Tony. I had the same. So first of all, I think maybe I'm wrong about this, Tony. So since you taught me, if I don't understand it correctly, I blame you. But basically, I think of hydroceles, there's two etiologies. Either it's a opening, so it's peritoneal fluid going in, or in the non-communicating hydroceles, there's either a micro hole or somehow it's secretory lining, and that's where it's coming from. And my question is, if in the latter, this wouldn't work. So that is why what I do is I laparoscopically bring the sac in, remove part of it, and then ligate it laparoscopically. What's your thought, Tony or Dr. Sun, on these non-communicating hydroceles?
Dr. Sun?
All right. Go ahead, Tony.
Todd, I think you're absolutely right. Most of the neonatal ones, though, I believe do have some kind of access. They may seal off with a flutter valve, so you can't push the fluid back out. Of course, you do get hydroceles of the cord, which are different, and I don't think communicate. And I predict that those ones will not necessarily need a ligation of the processus vaginalis, but really decompression of the cord. It would be a good question to see whether those ones actually reoccur.
Yeah.
Yeah.
I agree. Go ahead.
If you say if you have a recurrence, you may have a chance that processus vaginalis was still open, even if it was like a really small. So if you, every time you enter, you close that opening, even if you don't see a clear open, then you're addressing all those that will recur because you didn't see the opening.
Okay, so your point is it's always an opening. Hydrocele. Okay. All right. We got cut off. All right. Thank you, Dr. Sun.
Thank you.
Hopefully we'll see you again. All right. Take care. Thank you.
Well done.
Okay.